why talk about fever and return traveller now? Well, this is our malaria season, guys. So summer is when we see malaria in the UK, and that's because everyone's coming back from overseas with their malaria. We don't currently have endemic malaria in the UK, and so not just malaria, but other infections coming back to think about. And so what I really want to cover, and I hope that I can keep to time, is how to take a really drilled down travel history and what are the key points. Think about how that guides your investigation and your differential diagnosis, and then leads on into your management. A few updates on epidemiology because things change as climates change. And then also when you get stuck, where to get help. And of course, the bottom line of all of this is that we're more than happy to be called to offer PSID advice at any time. And I think it's really easy when you're faced with someone who's come back from overseas to kind of just go, your mind to go a bit kind of scattergun, and you think of sort of super rare things. You're worried about, oh my God, is there something that I need to put them in a side room for? Am I going to get in trouble for my PC? What do I do about the PPE? Have they got some weird and wonderful thing? And I think the whole point of this presentation, hopefully what you'll have confidence in afterwards, is being able to really think of a nice differential that actually narrows things down, and not kind of go to the rare and wonderful and the zebra straight away. That said, it is important to always just think about, actually, is there something that we need to, some transmission risk here, and just make sure you ask the questions about bleeding and any known contacts with any significant diseases while overseas. So that's my bit about the rare and wonderful stuff. And of course, not all returning travellers have a tropical disease. And actually, the vast majority of kids coming to ED after they've come back from overseas will just have a normal infection. They'll have whatever's going around, pertussis, measles, now a normal infection, a UTI, all those other things that we look for all the time as a general paediatricians. There will be a smaller proportion that do have a tropical infection that we don't want to miss. And there will also be children who've got a normal infection, but due to their either healthcare contacts or non-healthcare contacts overseas, there may be some particular resistance patterns within that organism that make it difficult to treat. And of course, sometimes fever isn't due to infection, and important never to forget the inflammatory and malignant causes. See if I get this to move on. So straight into some cases. So the first case is a 9-year-old girl who presents with 9 days of fever and non-bloody diarrhea to a central London ED. She's also had some vomiting for the last few days, but she's still drinking. She's got no other associated symptoms, and she's recently come back from Pakistan. And she's on no past medical history, no regular meds. So the key history of where have they been and when. Okay, so thinking about what was the purpose of their travel. So thinking about where have they been? So which countries, where they in those countries. I found it super helpful now to go in with your phone or your laptop, open Google Maps and get them to show you where they've been, and then with that, you want to get the dates. And actually, when you're doing that, you get, oh, this bit looks like it's right next to a sea. Did you go to the beach? Did you go swimming? Oh, it's a big lake. Did you go in the lake? Kind of allows you to start thinking about some of the exposures as well. So exactly where they've been. Did they just go to one country? Did they have travel stops en route? If they had travel stops, did they go out of the airport? Did they stay in the airport? What was the purpose of their travel? Was this a 5-star resort in Egypt, or actually was this much more rural travel, sleeping alongside animals, for example? Were they visiting family and friends? Super common at this time of year, people traveling back to Africa or India, Pakistan to visit relatives. And what did they do while they were there? Were they attending big celebrations, weddings, another common reason to travel, funerals, other mass gatherings, the Olympics? And thinking about their exposure. So what did they eat? So classically, I say, did you eat all at home? Did you have any food out? And if so, was that street food? Was it cooked in restaurants? Were you drinking bottled water? Were you drinking filtered water, tap water, well water? How did the water be cleaned? Are there any unpasteurized products? So goats, camels? And they've said about water exposures, so swimming or paddling in either fresh or seawater, any bites at all, any any other animal exposures, including dead animals, and a little bit about the detail of those animal exposures. So, you can go to a zoo, but if you stand 2 meters away from all the animals, you're very unlikely to pick anything up. If you're cuddling the dead cat that they found dying on the street, that does happen, then much more high risk. And any other unusual travel activities or even usual travel activities they may have been involved in. And why is it really important to think about where they've been? Because it can then allow you to start drilling down about what you need to think about. And I'm going to show a couple of tables from this really lovely paper in the BMJ. And you can see that quite quickly, just by narrowing it down, you can narrow down your list of infections to worry about. And the other question that I find is really helpful, particularly from children and families that are coming back from visiting friends and family, is actually what goes around in that area, what's going around at the moment, because you will find they will say, oh, well, actually there's loads of this particular parasite, or there's loads of this infection, but we never give that antibiotic because it's rubbish where we are. And so you can get some local epidemiology, even sort of through that patient contact. So then it's about the timing. So you've worked out where, you've worked out your exposure histories, when did they go, the exact dates, just got back 2 weeks ago, got back 3 months ago. It makes a big difference in what you're going to be looking for. I said about travel stopovers, if they are got a particular exposure, so a food and drink exposure, water exposure, again, the dates they were doing those activities, and the dates the symptoms started and how they evolved over time. And that allows you obviously to calculate an incubation period, which moves me on to my next graph from that lovely paper, where you can see then you can almost build up a sort of Venn diagram in your mind of you cross over the area, you cross over the incubation period, and then suddenly you've got a really narrow list of things to test for. And you can see the things that we worry about most acutely are things like the gastrointestinal illnesses, some of the arboviruses, and malaria, as well as your classic bacterial pathogens. And then as you get further out, it's more likely to be some of the more indolent conditions such as TB, schistome, leash. Important to know how they were where they were traveling. Did they have any pre-departure vaccines or prophylaxis? Did they take any bite avoidance methods such as nets, covering up, things like that? Were they sick while they were away? And if so, what healthcare contacts? Ideally, some sort of idea of what treatment they had, often information incomplete. And again, has anyone else around them been unwell? So coming back to this case, so remember this was the 9-year-old girl with 9 days of D and then some V and some fever. So she'd been in Karachi for a month and she'd come back 17 days ago. So you're looking for things that really have an incubation period between about 3 and 6 weeks. She was mainly visiting family. It was an urban setting. They had sort of air conditioning, lots of windows closed, and they mainly at home, and no one else was sick at that time, and good compliance with bottled water. She was pyrexial, but otherwise a fairly unremarkable examination apart from some right upper quadrant tenderness. So I always think that you've got kind of like your standard panel that you're going to send on anyone who's a returning traveller, even it's kind of symptom independent, and then you've got your more precise investigations. So you're going to send your standard bloods, and you might want to add a COAG if you're thinking maybe about sort of hemorrhagic things, but again, that's probably a little bit, value add. Parasitic infections, so you've got to have a really good reason not to send a malaria test, and there's a whole variety of tests, and where you're working will vary with what test you do. But most trusts will do a rapid diagnostic test as a screening test and then go on and do some films, and we'll talk a bit more about those. Be aware that someone who's not had much previous malaria exposure may have a very low parasitemia, and so their films may be negative, or very. You may have poor sensitivity at that low parasitemia, and so if you've got someone that's got ongoing symptoms who's come from a malaria area, we would suggest that you send 3 samples on separate times before you say that there's definitely no malaria there. Absolutely looking for parasites within the stool, so sending your stool for overcysts and parasites. Thinking of your bacterial things, you need to send blood, urine, stool, and throat cultures, and that's throat cultures looking for your normal group A strep and other UK pathogens. And the asterisk there is just to say that you may have a patient that is not passing stool, but actually you can still send rectal swabs and get a lot of information for them. They're not as sensitive as actual feces, but your lab will be able to process them, and you might get a positive. Similarly, we want to send viral samples, so extended viral respiratory panel and stool. And then thinking about resistant organisms, particularly if there's been healthcare contact overseas, so sending MRSA, CPA screens, Candida auris screen if they've been overseas. We really don't want that in our hospitals, so we really want to isolate appropriately. And if they've got respiratory symptoms and come back from the Middle East, then you should be sending respiratory samples for MERS and isolating until you've got those back. And then, because everyone always thinks of something else after you've already bled the child, do send a serum save so you can add on. If they've got any focal symptoms, then they should be imaged. And if you've got any derangement in LFTs and you want to send a hepatitis screen, you might want to be thinking about other serologies, and we'll come on to those. And if someone's lived for a long time in a country or they've got specific risk factors, then to send HIV and TB, but I wouldn't routinely do that on everyone. So this 9-year-old from Pakistan with her DMV illness, febrile gastro illness, so she had a mild transaminitis. She's got a good going CRP of 136, but her initial malaria and hepatitis screen is all negative, as her screening for resistant organisms and hepatitis. So she got admitted and she was commenced on ceftriaxone and azithromycin and fluids, and she was still spiking 2 days in, but things seemed to be starting to improve. She went on to have an ultrasound abdomen, and it's always lovely when the radiologist tells you what the diagnosis is rather than just what they can see. And so she had this terminal ileitis and some necrotic lymph nodes intra-abdominally, and they wondered about whether this could be infectious, but obviously can never rule out other things. And her blood culture grew gram-negative bacilli. Her stool didn't grow anything, and we do both stool cultures and PCR, so PCR will be more sensitive than culture. And she had an E. coli, which was an ESBL in the urine, but probably a contaminant, given no white cells and a negative repeat. So given all of that, what do you think the diagnosis is?
Yeah, probably we just typed in typhoid.
Perfect. Yeah, so this is enteric fever. Or typhoid, in this case was due to typhoid, and so you can see her fever chart gradually settled on the Keftri and the azithro over a number of days, and her blood culture confirmed Salmonella typhi, which was ceftriaxone sensitive and resistant to a number of other antibiotics, as we commonly see. So she was managed in a side room. So she'd been admitted into a side room. She was managed in a side room. She had 10 days of treatment. She got better. Sibling had some symptoms, but he actually didn't have typhoid. And important thing to always remember to notify UKHPA for this. And they will often request samples from close or household contacts, but you can quickly screen them yourself to work out how worried you are. And so really what you want to know is if this young person is living with anyone, is living with anyone who is a food handler, or works with vulnerable people from a health point of view. So maybe someone who works in a healthcare setting, because those people may be carrying typhoid, may be asymptomatic and may transmit to other people. So briefly about enteric fever. So Salmonella breaks roughly down into typhoidal serotypes or non-typhoidal. The non-typhoidal don't tend to make you super sick, but they can cause gastro illness, food poisoning. And so we don't routinely treat those with antibiotics unless the patient's particularly vulnerable, either very young, very old, or immunocompromised. The typhoidal, so typhoid and paratyphoid, will cause what we classically call enteric fever. That's the clinical syndrome. And we do treat those. And typhoid is, there's a pretty widespread distribution, you can see, and you can also see that particularly common in younger people. And this is a multi-organ disease, multi-organ condition. So they're classically most likely to have fever and GI symptoms, and they may fluctuate between constipation and diarrhea, but can also have neurology, so reduced GCS and seizures, rash, which if you sample, you might be able to get the typhoid from there, and other cardiovascular, renal and hematological complaints. And the main problem with typhoid, apart from making people super sick, is that resistance is really an ever increasing battle. And you can see that previously we used to use fluoroquinolones, but now, so if you look at the CYP-NS column of that diagram there on the right, you can see that lots of countries have really high rates of resistance to fluoroquinolones, and so we increasingly moved on to third generation cephalosporins as first line treatment for anyone coming back with suspected typhoid. Obviously good because they cover lots of other things as well, but in particular areas of the world, and this is particularly so in Pakistan and the Punjab region, there are high rates of cephalosporin resistance, and so now we're moving that if you now the UK guidance is that if you come back from those areas, that meropenem and or plus or not or meropenem or meropenem plus azithromycin as your first line treatment from any one returning from the Punjab with suspected typhoid. And these patients classically spike for a long time before they settle, and say 5-7 days the fever is not uncommon, and you just need to make sure that otherwise things are improving. Keep checking to check they've got no dissemination of disease, no joints involved and things like that. Feel free to reach out for any help. And important to say that we do have vaccinations against typhoid. They're not perfect, but actually the prevention is very much better than cure. Malaria. So as I'm sure you're all aware, the multiple types of malaria, so 5 different types, and the one that we worry most about is falciparum, which is most prevalent in the African subcontinent. And they're all spread by mosquitoes, and there is no vaccine available for travellers. Families often come and ask or think they've had all their travel vaccines, so they're protected against malaria. There is a vaccine available now for the local populations, but it's not a travel vaccine. That's not how it works. And depending on your previous malaria exposure, really depends how sick you're going to get. So if you're an adult living somewhere where there's ongoing malaria transmission throughout the year, then you're likely to have frequent asymptomatic parasitemias. However, if you are a traveller or a child who's coming across malaria for the first time, you're more likely to have a much more severe course of malaria. And sadly, there are a number of deaths each year in the UK in travellers returning with malaria. And they can be, as I'm sure you know, very non-specific at their initial presentation. So they may just have fever and some sort of aches and pains, headache, flu-like symptoms, or they may have more kind of clinically apparent symptoms at presentation. Okay, so yeah, it's really important that when a child comes in who has malaria, that we do all the investigations to see if it's severe, because if you've got severe malaria, then you're much more likely to deteriorate quickly, you're much more likely to need HDU, ITU, and you're much more likely to die. And so the treatment changes, yeah. And so so these are the 11 features of severe malaria, and unfortunately I don't have like some fancy mnemonic or anything to remember them, and so I just looked them up. There's lots of guidelines out there to help you with that. But starting from the left here, so neurological presentation, so either fall in GCS, seizures, they can have dystonic posturing, and similarly to sort of along that line is what is called more commonly in Africa as prostration, which means really severe weakness and inability to sit. They can be shocked and have a metabolic acidosis or high lactate, and you can see a gas here, which is utterly awful, and I don't suspect this child survived, but this child had several features of severe malaria. So they were severely acidotic. They had a glucose, it says 32 milligrams per deciliter, but actually in what our terms we would call that 1.6. They had a hemoglobin of 34 and they had the severe acidosis. So they had lots of features of severe malaria. So a HB less than 80. Platelets are not a feature of severe malaria. They commonly see in the thrombocytopenia. They can have renal dysfunction. The hypoglycemia, very common and very important to monitor for. Jaundice, so that child had jaundice, which is why she would be classed as severe malaria. A parasitemia in the UK of greater than 2%. ARDS, which we tend to see more commonly in adults with severe malaria, but important to be cautious with your fluids and monitoring for that. They can get coagulopathies, and then we've mentioned the shock. So, you know, on top of all your routine blood, it's important to make sure you've done a clotting, you've done a gas, you know the parasite count. And some of these things may take time to come back. And so if there's uncertainty, you treat as severe and then de-escalate later. And just to note that pregnant women are particularly at risk of malaria and can transmit to their baby. And so when you're seeing the child, always be aware who else has been traveling. Is there anyone pregnant? Do they need to be seen urgently? So as I alluded to, we've got lots of different ways of diagnosing malaria in the UK, and that's partly because we are less experienced because we see it less frequently, and so we've come up with some molecular testing that takes some of the takes out some of the human factors associated. And so some centres will use a LAMP, which is a molecular test, which is a very quick, easy test. It's highly specific, but it won't give you a species. It won't quantify how bad your parasitemia is, but it's, you know, can be sat in any lab in anywhere where they don't get very much malaria. Yep, so they might screen with a LAMP. Most places will do a rapid diagnostic test. So this is an antigen detected test. So it looks for antigens on the malaria parasite. Some malaria parasites will not have the antigens it's detecting. So you can miss cases of malaria with this, but that is a minority. The antigens will remain positive for a couple of weeks roughly after someone's been treated for malaria. So if someone comes back from overseas with a story that they've been treated for malaria, they've come back and now they're febrile again and they've got a positive RDT, it may be that they've got malaria, or it may be that's just a residual positivity from before and actually they've got another cause from their fever. So bear that in mind. But again, it's a lateral flow test. It doesn't require any particular laboratory skill. The blood film, you know, previously was kind of the gold standard, and still has it's still important to you in someone that's got malaria because it gives you information that some of these other tests don't. And so it can allow you to speciate. So you send a full blood count in an EDTA, but what the lab do is create thick and film films. And the thick film is to look for the parasites. You've got loads of red cells, so you can look to see if there's any parasites there. So that's for sensitivity. Once you've found your malaria parasites, you then look at the thin film where you've just got one layer of red cells to look for the morphology of the malaria parasite to see if you can work out which species it is, okay? And that will also, you can also get then your parasite count from that, your percentage as well. Yeah, so the film will give you a lot of information. The RDTs can give you some species information, but the film will give you more. But you need to be experienced at looking at it. And then finally, the UKSSA run PCRs. So they're a send-away tests. They're highly sensitive, highly specific, but there's a turnaround time associated because it is a send-away. And actually all malaria positive films will be sent to the ref lab eventually. But if you want to, you can ask earlier. So you think someone's got malaria, they've got features of severe malaria, or you don't know their parasite count and you need to treat them as malaria. So this is a time critical thing, treating them. They can deteriorate quickly. It's a bit like your golden hour for sepsis. So you need to give them IV artesunate. It's not something to wait till they get up to the ward. It needs to be given once that diagnosis is made while they're still in ED, because delays here can be fatal. But you could equally have a patient who's got malaria, it's falciparum, but you've got all the information back and you're happy this is non-severe. Okay, so now you've got two options. Ideally, in the UK, we would advocate to admit the patient just to make sure that they can tolerate their medicines. But lots of people with malaria have lots of experience with malaria. It may be difficult to get them to agree to come into hospital, but that has to be the position we take as healthcare professionals. So then we can, if they're tolerating a good amount of oral food, they can have enteral treatment. And so the ones that we treat with either a Malarone or Riomit, Riomit's an artesunate combination therapy, they are dependent on you eating the fat-dependent absorption. So if someone's not eating, they're vomiting, then they should be on IV treatment. And just to say that both of these have slightly skewy schedules in terms of how often you give it. So it's important to be very clear to make sure everything's written down in terms of the frequency of the dosing. And if they've got non-falciparum, so you're therefore not expecting them to get as severely unwell, they're more likely to not need admission, and you can treat them with oral Riomet, but then they're going to need some primaquine to clear those liver stages that you remember that Vivex and Ovali has. And so remember to send your G6PD testing on admission, so you've got that result back once they've completed their Riomet course and are ready to have their primaquine clearance. So be aware of all the supportive care associated. So these children can deteriorate quickly. You'd have a low threshold for HDU care, particularly if they've got features of severe malaria. They do need regular neuro, obs, and blood sugars, particularly if they're young. If you've got malaria, you're more likely to also have gram-negative sepsis, so make sure they're on broad-spectrum antibiotics. We routinely give ceftriaxone. I've mentioned about the fluid management. They will drop, or they're very likely to drop their platelets. You don't need to transfuse them unless they're symptomatic from that. And similarly, their HB, again, monitoring and seeing what their symptoms are. This is notifiable, and we've said about checking other travellers. Very quickly, the third case. So this is a slightly different story. So other two infections, life-threatening, need prompt antibiotic and anti-malarial treatment. So this is a 13-year-old girl coming back from St. Lucia with fever, rash, anorexia, and lethargy. She'd only come back I think in the last week. She'd been staying in a lovely resort, having a lovely time, but she had lots of bites, and she'd actually seen a doctor there because she'd had some rash around an insect bite, which was felt to be cellulitis. But when she came into this was a local hospital, she actually looked quite unwell. She was rigoring, she was flushed, she had puffy eyes, she was pyrexial and tachycardic. She had some arthropathy of her ankles, and she had this diffuse rash, and I'm sorry I don't have pictures, but the notes were like, maybe this is just sunburn. And her bloods also were like not very exciting. Of a CRP of only 36. She had normal platelets, so always think about the platelets because they often drop in many of the tropical infections, including this one. And she was commenced on ceftriaxone, and she sort of maybe made some improvement or maybe just got a bit better and went home on some Karamox. And her bloods, which had been sent away to the reference lab, came back to say that she had chikungunya, and they'd done a whole panel and everything else was negative. So she's got an arbovirus infection. So arboviruses are infections that are transmitted by mainly mosquitoes and ticks and some other insects. And there's a huge list, and they've all got a very specific geographical, prevalence. But the main ones that you will see are, because they're the most widespread, are dengue and chikungunya and maybe some Zika. And so chikungunya, because people don't really know much about chikungunya, apart from the fact it's got a funny name. So this is an arbovirus. It is very widespread in its distribution. Come back with a short incubation period. So someone coming back 6 weeks after they've come, this is not going to be chick. Generally fever and painful muscles and joints. Classically some back pain, other non-specific symptoms, headache and fever and vomiting, but also quite likely to have eye symptoms, so eye pain or redness, swelling, and can also, like this girl, have some facial edema and pretty much any rash under the sun. And geographically, this is very intertwined with dengue, and also symptomology very intertwined with dengue. But there are some clues. The arthralgia is more prevalent in and more predominant in chick compared to dengue. And unlike dengue, you can't get the hemorrhagic shock. So you remember with your first dengue infection, you get your non-specific kind of all of these symptoms. And then with your second infection, then you can go on and develop hemorrhagic shock, drop your platelets, coagulopathy, and that can be life-threatening, and you don't get that element with chikungunya. And both of these, and in fact nearly all of the arboviruses, you can get thrombocytopenia and often lymphopenia as well. And this is the sort of latest alert really to come out of UKHSA about arboviruses, and that due to climate change, the climate which sustain, or the temperatures that sustain these vectors, these mosquito vectors, now include much of Europe, as they did historically. And so we are seeing, and we have seen this year, local transmission of dengue, West Nile virus, and Crimean Congo hemorrhagic fever within southern Europe, so Italy, France, and Greece. Even cases in Paris, which is quite far north of some of these conditions, and of course currently having a Olympiads. So your travel history really must not just focus on long haul flights, but thinking also about all of those more regular summer holiday destinations into the continent. And because it's impossible to know what's going on all over the whole world all of the time, the easiest way to find out what's going from an outbreak, so if you're worried about hemorrhagic fevers, you're thinking, actually, do I need to worry about France, Greece, Sweden, what's in Sweden, that this is the NAFNAC website. Just Google NAFNAC, you go to the outbreak surveillance, you put in the country, and it tells you what's being reported at the moment. And the other really helpful resource that we use a lot is the IFS, Imported Fever Service, and their lab, which is known as RIPPLE, Rare and Imported Pathogen Lab. And so this is a UK-wide service offered through UKHSA and some of the travel, London School, for example. And you can ring for advice, but you can also send samples there, and they will do a geographic panel. So you tell them exactly where your patient's been and when, and the when's important to know whether they should do serology or PCRs. And then they go, okay, they have this closely guarded secret of what's going around, or what panel that is on each, depending where the patient's been. They run the blood, and then they come back to you and say, yes, they had West Nile, they had dengue, they had chick, they had whatever. It's not a rapid turnaround unless you're looking for a viral hemorrhagic fever, so probably 1 to 2 weeks, but often gives you really useful information to feed back to families. And so that is near the end. So just to say that, remember, common things are common, and actually probably about 90% of fever in return traveller, if you're looking at travel-borne infections as opposed to just the flus, etc., is going to be malaria, typhoid, and then your arboviruses, so your dengue and your chikungunya, maybe your Zika. So actually it's actually a relatively small number of conditions that are causing the most of these tropical infections. Obviously, the two that again are really cause a life-threatening condition there that are common are the malaria and the typhoid. So make sure you're looking for and treating these. Think about your other life-threatening but not related to traveller conditions. Everything else you've got time to think about and to research, and you can call us at any time. You can call your local micro, whoever your local pulse of call, so that we love return traveller. It's so much more interesting than many of the other things that we deal with, and so we love to be called about these. And just a reminder, so please, because every year there's patients that come back that come to A&E, no one asks about travel because you're busy thinking of all the other things, and they don't disclose that information. So please remember to ask about travel in anyone coming into A&E with a fever. And also, if you're seeing people in clinic and it's this time of year, ask, are you traveling? The number of families that go, oh yeah, we're traveling, but we haven't sought any travel advice, and that's an opportunity to get in there and trying to prevent them coming sick. And happy to take any questions. And Eleni and Sarah, who are now probably sending me evils through Teams because I've just put their phone number on this screen. But yes, that's our fellow number, and that's someone there 9 till 5 Monday to Friday. And out of hours, we do have consultant cover 24/7.